So basically, it's a 60-year-old male, had a squint, cataract, IOL, radial buccal, 6-7 years back, had a buccal infection, buccal was removed and then came back with recurrent detachment and underwent vitrectomy, re-scleral buckling and silicone oil injection in 2011. Now on first post-op day, his IOP was okay. Retina was attached, but he has 360-degree choroidal detachment. He was treated with topical steroids, cycloplegics, and systemic steroid as well, tapering doses. At first and second week post-op, the retinal choroidal detachment was reduced in nasal and inferior quadrant, but other quadrants still persist. At 2-month follow-up, his vision was 612 and 6. Eye was quiet. Pressure was 14 millimeter of mercury. Attached retina vitreous cavity was clear, basically, but still has a persistent choroidal detachment in temporal and superior quadrant. And the same thing continued in 3 months, 4 months, and 6-month follow-up. He reported to us or referred to us for second opinion 8 months post-op. He was absolutely asymptomatic, comfortably managing everything. Vision now was 624, which was reported initially was 612 and 6. Now it's 64 and 6, 624 and 6. Intraocular pressure was still normal. What fundus examination revealed is, you see here, you have attached nasal, nasal part, but temporal side, though retina was attached, having quite a significantly large choroidal detachment. He had a, you see reflex here, is basically showing incomplete silicone oil field. So what could have caused this persistent, apparently serious choroidal detachment, and how we should manage this case? So we asked for ultrasonography, why the choroidals are there. Pressure is normal. This is one frame. What you see is a serous choroidal, I think, little bit enlarged globe here, and serous fluid in a suprachoroidal space, rest of the retina attached. But when you see other frame, what you see here is reverberation, multiple reverberation, enlargement of globe. So this area looks more or less normal axial length, probably because he has incomplete field, and axis was going this side, so this looks more or less out. But this, you have enlargement and you have multiple reversions, suspecting having a obviously suprachoroidal silicone oil. Now the option was, because patient is asymptomatic, pressure is normal, vision is good. Now to observe or to go with silicone oil removal. So we discuss with patient says, okay, let us go ahead with oil removal, because vision was slowly, progressively going down. So what we cut on the sclera and what is coming out, as you see here, your diagnosis was right. They have a huge amount of suprachoroidal oil. Entire thing was suprachoroidal silicone oil. Its draining is not that difficult. It's like comes like SRF drainage, but here suprachoroidal fluid. You cut there, you inject some saline, form the globe, build up the pressure, and go back and again drain the suprachoroidal oil. And then after that, whatever leftover oil was there in the vitreous cavity, we did silicone oil removal. Oil is out, and then suture the sclerotomy site. So at 1 week post-surgery, retina was attached, but at 3 weeks, he came with a recurrent detachment, but we could not see any obvious break. So we did advise re-surgery to the patient. He decided against surgery. So I would like to have a discussion here with the panel. How would you suspect the suprachoroidal oil? Would you observe or plan silicone oil removal in this asymptomatic patient with an attached retina, with a normal IOP, but having a choroidal detachment? And what would be the consequences if the oil is left behind?
So truthfully, like I've only seen one case, but I've not seen such a large extent. It was more of a localized near the port area. So it was seen as a non-resolving CD after like 2-3 weeks. Just had a doubt, and one of my juniors' cases, we just had a similar cut down and drainage. So I couldn't make out, because the oil was totally filling the vitreous cavity. I couldn't make out on ultrasound any difference. Yeah. So I don't know how to suspect this. In that case, only case which I had seen was like a non-resolving. It was not resolving. I couldn't explain why it was still there actually.
Yeah, mound is not resolving with in spite of all other treatment, and with you have a choroidal detachment, no hypotony, eye is absolutely quiet, and obviously incomplete fill. Probably that's another clue. You feel or force you to suspect something is not right there, and particularly again superior area oil is going to just slowly, gradually shift upward. Inferior retina is absolutely fine attached, and superior choroidal detachment is mainly involving the superior part. So. How this oil could have entered the suprachoroidal space? This again probably hypothetical, but while injecting, you have infusion cannula partly in a suprachoroidal space, partly in a vitreous cavity. So while injecting, because oil is coming inside the eye, you feel that it is filling. You don't realize part of it still going in the suprachoroidal space, and probably that explains the day one he had a choroidal detachment. We did not suspect that time that this oil would have gone suprachoroidal space. Or sometime, particularly happen in trauma cases, this was not an injury case, we have sometimes significant damage, even in choroid disintegrates, retina disintegrates, and there is a big hole sometimes, choroidal hole sort of thing. And with that type of situation, slowly vitreous cavity oil trickle through this opening in the choroid, goes up, settle superior part area, low inferior part probably settle down. That's another possibility I could think of. Mahesh, any comments? Any comments?
So, is it that always you see, I mean, you said that it always trickles up, but since it's in the suprachoroidal space, does it really follow that kind of a gravity?
Well, not really exactly that way, but to some extent, that's why temporal part is also detached. This is one of the clues I'm saying, because we have a vessels running across choroid and sclera in between, so you have a hindrance everywhere. It's not like a freely moving under the retina, what it goes in superior or in a vitreous cavity. No, not that way. Now, the most important question I have here is, what would have happened if you left the oil as it is?
No answer to that, sir. But I think it not a good thing to leave it inside.
Absolutely. So that's exactly what we failed, and that's the reason we offer surgery. But then look back now, he come back with a recurrence, and he refused the surgery. He had 6/12 and 6 vision in that eye. So, I mean, it's easy to think in other way now, but before surgery, probably, yes, we thought that's a right option to take off. So, anything else? We'll stop. Or you have a few minutes?
Yeah, you have 2 more minutes. If there are any questions from the audience.
Any question from audience?
Mike, please.
What would have been the consequence of leaving the silicon in place? I mean,
we do not know exactly. That's why we do not know. We do not have any literature support as such. I do not have answer for that question. But persistent choroidal detachment, yes, probably over a period of time, I would have emulsified. I do not know. Again, whether we will emulsify or not, that also don't have answer. But the only reason was when he saw his record shows 6/12 vision, he came to us gradually, slowly, vision is going down, and probably that rather on this side, giving that option of removal of the oil. But that's exactly the same question. I don't have answer for this question.
Yeah, Dr. Murli?
I just wondered if you had removed the suprachoroidal oil and left the oil in place, top it up, would it have been better in hindsight? I mean, we don't know.
We don't know.
That's,
yeah.
Maybe in such a situation, is it better to continue the tamponade for a couple of months more? I wonder. I don't know. I don't think.
No, but then anytime, anywhere, so see, somewhere something is which probably we miss on the table. I check everything, because even after 2 months we would have removed oil, he would have come back with detachment. Somewhere something, probably if you remove the oil and though there is no break, still you want to go barrage blindly, everything 360 degree, which generally I don't prefer, because excessive laser, again further contraction, worsening the traction. I am generally not in favor of blind laser 360 degree. So again, you can debate, particularly looking back this case, probably you can debate that I should have done that. I don't know.
Just as an extension, Pramod, supposing this were a one-eyed patient, I mean hypothetically, if this were a one-eyed patient and the same situation was there, would your plan have been any different? And the cause of the reduced vision, I don't think can be attributed to the persistent suprachoroidal oil. I mean, the reason might have been something else.
No, it's probably what is happening is slowly over a period of time, you have folds are building up. Probably he will develop perisiliconyl proliferation. You have membranes growing in the vitreous. It was again incomplete fill, obviously. One-eyed, Again, the same scenario, I would have given option to the patient. I would have asked patient to decide. Again, this time also, it was patient's call. Though we spoke to him, this again, counseling is very, very important when you deal with this type of cases. Talk to patient, make them understand, and tell them both the situations, plus and minus on either side. So let patient decide. It's the patient's call, not you. Okay, you are not forcing the patient to do it. And just make an entry, document it, that yes, that's why I discuss with patient. Generally, I tell them most of the time, you don't tell me now, you go back home, discuss, let the things sink, take your own time, talk to your family, let rational thinking prevail, and come back and let me know.
There are no further questions. Thanks, Dr. Pramod.
Yeah. Thank you.
At least I'm finally seen as a full person rather than a half. I had to move from Mac to Windows. I apologize for all the confusion.
I am not the only person
So
having a problem.
the point of this session is this, that like what the textbooks don't teach. So that's what it is. Like, and in every case there is something to learn about, and Dr. Pramod showed along only one case. Let's go through a series of cases in the next 10 minutes or so. Can you have the lights off, please? So this was a 47-year-old patient who presented a sudden onset of subretinal hemorrhage. There was no history of anything prior to that, and the retina was right behind the lens actually, and it was filled with vitreous hemorrhage. So one thing, it was a mass lesion. We did an ultrasound and an MRI. It showed something as a mass lesion. So in the presence of mass lesion, we cannot intervene, and no mass lesion that we know of presents like this with an acute loss of vision and the subretinal hemorrhage right, pushing the retina behind the lens. Waited for about a month, and then the hemorrhage decreased to some extent, but there was something like choroidal detachment here. And this time the MRI, they said there is no mass inside the eye. So if it was a mass, it should have increased in size, it should not have decreased. So we went ahead and tried draining it. So I thought of draining transconjunctively, which I do for Coats disease, and once I put the needle, nothing came. Then this blood came into the subconjunctival space. So we were forced to open up and drain transclearly. So I'm such a fast surgeon, not really. So cut down and see the amount of blood which is gushing out. And do not have expulsive hemorrhage or anything like that. This happened spontaneously. In between, this case took another curious turn. This blood we sent for cytology, and one of the labs said that there was some atypical cells that went on. Then we went ahead and completed the vitrectomy, and there was a huge amount of subretinal hemorrhage. Now we are able to see the disc. And temporarily beneath the macula there was a large area of subretinal hemorrhage which we could not see. And this was the early post-op period. You can see the vitreous cavity quite clear, huge amount of subretinal hemorrhage which decreased over time. So what this patient has is peripheral exudative hemorrhagic chorioretinopathy. It's a retrospective diagnosis made after draining the blood and seeing inside. So what did we learn from this case? We learned that it can present with extensive subretinal hemorrhage, so much so that the retina can be present right behind the lens, much like in the advanced stage of Coats disease. It can mimic an intraocular tumor, and we usually wait for about a couple of months to see if the lesion decreases in size or increases in size. If it increases, likely to be a tumor. If it decreases, likely it's not a tumor but it's a hematoma. Can present abruptly in a patient and can permanently blind a patient. We have had a couple of other patients who have become NPL, which is subsequent to a sudden hemorrhage like this. So these patients usually ask, what do I do about the other eye? And the other eye, when you see, we don't find any evidence of exudative disease. In such a situation, one idea would be to do a wide field ICG angiography to look for this peripheral polypoidal lesions in the extreme periphery and prophylactically treat them. In the previous two patients whom I have had this problem, we have not been able to identify the polypoidal disease in the other eye. So this was a recent patient about a couple of weeks back. This lady came, 22-year-old with exudative RD and loss of vision. And this is how she looked like, some vague subretinal exudate-like lesion. You can see the vitreous cavity is quite clear. You are not able to see the disc, and there's an exudative retinal detachment. There was something like a mass lesion out here. And the other eye, when we looked at it, looked like it's a enucleated eye. When we asked her, she said like she had a trauma at about 4 years of age, and then like the eye had been enucleated. So the DDs we entertained were whether it's an infective or an inflammatory granuloma, but then there were absolutely no evidence of inflammation in the vitreous cavity. Whether it could be sympathetic ophthalmia. But if it's sympathetic ophthalmia, why would it present as a mass lesion? Is it infiltrative disease, lymphoma, leukemia? I have not seen of a lymphoma presenting with such a huge mass lesion. So planned for a biopsy. But then on the day of the biopsy, I looked at the patient once again and put things together. The other eye being enucleated is not coincidental. It is just that the patient has probably presented with opacity in the cornea, and she was 22 years of age and she didn't have any previous history. So what you're looking at is retinoblastoma in an adult. So this is, why does it happen? Could it be a malignant transformation of the retinocytoma? We don't know. So obviously this lady has bilateral retinoblastoma. One eye has been enucleated for, we don't know if they don't know the reason at all or not. This eye was a retinocytoma which has subsequently converted to a retinoblastoma when she became an adult. But surprisingly, retinoblastoma in adults are most often unilateral, and most often they don't respond too well to treatment. And even if they respond, they ultimately would have to be enucleated. So the most important is a high index of suspicion is required. Even for a person who has been dealing with these tumors for 20 years, when he saw the patient for the first time, I didn't put things together. I didn't put that like other eye enucleated. Initially, I actually saw the photographs, and subsequently, when I saw the patient, only things came together. It was actually posted for biopsy under me. But then, like when I saw the patient, then things came together. So we need to have a high degree of suspicion as far as retinoblastoma is concerned. It presents as an amylotic mass. You can have vitreous seeds and subretinal seeds. So look for it if in case a patient presents like this. So do not disregard history. So though the patient says by some reason the enucleation was done, probe deeper. So even if it's staring at you, we can miss the diagnosis, and mass presenting without signs of inflammation is not likely to be an inflammatory mass. This is a 17-year-old presenting with macular edema, and if you note carefully, you know the reason for the macular edema. Yes, there are two dilated vessels out here. We are going on to a peripheral retinal angioma, pretty large angioma. There's one more superior-temporally, and this is the other eye showing multiple tumors, and the macula being normal, partly treated. So this was pretty large. So couldn't do brachy, couldn't do laser, because it was, couldn't do laser, couldn't do cryo, it was fairly large. So we did brachytherapy. So we treated this with brachytherapy and the tumor shrank this way. And the superior tumor, we treated brachytherapy and shrank this way. And we thought everything was fine. But about a year later, patient presented with vitreous hemorrhage. And underneath had an regmatogenous retinal detachment. So this is the vitrectomy. Earlier days we used to resect these tumors. Go ahead, aggressively cut these tumors off, put oil. But now we know better. Resecting these tumors ultimately results in phthisis. So this is a PVD induction. You can see the large clump of exudates under the macula. Peripheral vitrectomy, very, very careful vitrectomy not to create a retinal break. Additionally, close to the tumor particularly because of the associated severe fibrosis, which is what you see here. So this is a nasal tumor. So very careful dissection. And subsequently, we treated the feeder vessels. This is the feeder vessel treatment being done. The feeding arteriole and venule were treated. Then put silicone oil and an external 42 buckle to support. And this is the response. You can see the exudates have gone away. The tumors have regressed. The retina remains attached, and subsequently managed to remove the oil. Patient maintains about 6-12 vision. So what did we learn? So we need to be conservative yet aggressive. Even the smallest of the tumors in VHL disease has to be treated. We cannot wait for it to grow. If we wait for it to grow, then we cannot get it back. And brachytherapy is effective, takes time for the response to see, and all is not lost in VHL. This is how it used to be earlier. This is a 68-year-old patient who presented bilateral vitritis, and we thought we'll do a diagnostic vitrectomy in one eye. I was wondering if it was an endogenous endophthalmitis, fungal endophthalmitis. That's what it looked like. But then look at the fundus. Looks like frosted branchitis. After removing the vitreous, we found that what looks like frosted branchitis and extensive infiltrative disease in the eye. So we're wondering what it is. We treated with antifungal, antiviral, antibiotic, and steroids. Patient didn't get better. And this eye already didn't have vision. The other eye continued to lose vision. So in desperation, we did another biopsy and did an MRI. And that showed an infiltrative disease. So we thought it could be lymphoma. We sent it to neurosurgeon. Neurosurgeon said, no, this is glioma. It's got nothing to do with your eye. You treat your eye separately. So again, the patient continued to lose vision. went ahead and did a biopsy, and as a therapeutic challenge, it gave intravitreal methotrexate, just one single dose. Subsequently, you can see the eye clearing up. So what we learned, and this cytology this time, after stopping steroids for 2 weeks, showed that this patient indeed had lymphoma. So lymphoma can present as frosted branch angiitis rarely, and this is not something which is commonly reported. This is an extremely rare presentation. And when we are pushed against the wall, it's not a bad idea to do a therapeutic challenge. For instance, in this I gave methotrexate, and that kind of proved that what we were treating was correct, on the right track. And other specialists, yes, sometimes think that ophthalmologists know zilch about systemic disease. So this was a 12-year-old with subretinal mass. So this looks partly like a hemangioma, had an exudative retinal detachment. But what is intriguing is the different colors. You see a little orange here, a little yellow here, then exudative retinal detachment. So what this is usually a tuberculous abscess, a tubercular granuloma. And we thought it was tubercular granuloma and started the patient at ATT. And after 3 days, it got worse. So the exudative retinal detachment got worse. And patient said that she is able to see much worse. So are we on the right track or not? Yes, we are on the right track. Only thing is the tuberculous abscess gets worse after starting ATT immediately, and then started systemic steroids, and this is a response subsequently. So this is a classic case of tubercular granuloma. You see the clue is in the multiple hues the mass presents with. See the white here, you see the yellow here, and the orange here. So and if the color changes over a period of weeks, it evolves to an abscess. So the color changes over a period of weeks. When you see a mass like this, suspect tubercular abscess. I think we'll skip that. So this is the last case. So this is a patient who underwent vitrectomy in one eye for a regmatous retinal detachment elsewhere. And about a week later, patient presented to the doctor saying the other eye vision is less. On this side, where the patient had a vitrectomy, patient had only light perception vision. And the other eye, the doctor did a visual fields and found hemianopia. So what is the reason for hemianopia in the other eye after vitrectomy in one eye? The clue is here. So this is silicon oil, and this is silicon oil in the chiasma. So silicon oil had tracked to the chiasma and resulted in the hemianopia in the other eye. And this is the neurosurgery. So we took him along to a neurosurgeon, did a craniotomy, and this is the optic nerve. Of course, the optic nerve we see is different from what they see. This is the optic nerve, and you see the cut here. This is the slit opened up, and this is the silicon oil which is being removed from within the chiasma and the optic nerve. And this is the visual result after silicon oil removal. The visual field improved. So what did I learn from this? Neurosurgeons can also do SOR. Thank you very much. I think that's my time. If there are any questions or comments about any of the cases.
Mahesh, in the first case with the massive subretinal hemorrhage which you were draining, just a thought, do you think an infusion in place would have been safer when draining such a large amount? Because I saw that there was
no, the retina was right behind the lens. So wherever I put the infusion would have gone under the retina. That's why I didn't put it. So I wanted a space. So I drained it, then I tried injecting through the anterior chamber to create a space. That's why it went like that. So Dr. Rajesh will be presenting his series of next cases, but Avinash is not able to make it. So Dr. Rajesh will be presenting Avinash cases.
I know I'm a chief supplement too, sir. But anyhow, he's given his wonderful talk, so I'll just try to brief up in the way that I understood it. Kindly attention towards the fundus photos. This is a patient who has a progression of CMV retinitis despite the patient being on oral vanillin cyclovir. He is a retroviral positive patient. So these are the lesions which are there on the fundus. The highlights of the lesions is that it is a multifocal retinitis, several patches of there. There is hyperpigmented scar as well as there is intense vitritis. The most important of all of these three is an additional factor, that is the absence of hemorrhages. So what it tells us is it's not just a CMV retinitis, it is something else added to that. So if at all we suspect anything else, what are the other things? In this case, yes, it's toxoplasmosis. Try to rule out by doing a serology. The toxoplasmosis on my left hand, vice versa, CMV retinitis on my right. You can see that CMV retinitis is a large patchy single lesion with a lot of intraretinal hemorrhages all along the lesion. But as far as toxo is concerned, I have already enumerated that it doesn't have hemorrhages, it has multifocal spots. So the four most important points to consider a toxoplasmosis in a patient with retroviral positive is if it's bilateral and multifocal in nature, if there is absence or minimal hemorrhages along the lesions, and the presence of intense vitritis. CMV also has, but the intensity of the vitritis is much less. And the second thing is, like in an immunocompromised patient, there is a vertical and horizontal spread of the toxo lesion. Vice versa, a person who is immunocompetent, in which it's only vertical spread. So as far as treatment is concerned, the patient is already receiving in hard therapy because it's a retroviral positive. As far as the toxo is concerned, the treatment should be much longer than the conventional 6 weeks that we give, and pyrimethamine should be avoided in such patients. Long-term dosage of maintenance dose of anti-toxoplasma is very essential in these patients till we achieve a CD4 count of more than 200. So this is a patient, the same patient, after 3 months of successful treatment with Bactrim DS, you could see how wonderfully the lesions have healed up, forming a hypertrophic scar. The second case is a 32-year-old female with decrease in vision in her right eye for the past 10 days was referred with a diagnosis of choroiditis. Why? Because there was a yellow nodular lesion in the posterior pole. So whenever a patient with nodular such lesion comes, it is always better to rule out nodular posterior scleritis. So this is the patient. The vision is 20/100. There is nothing much of vitritis, just an yellow nodular lesion in the posterior pole, just next to temporal to the fovea. The 3 easy point that we always look into to differentiate a choroiditis, vice versa, and nodular posterior scleritis. The first one, most important, is the FFA, where the intensity of early hypofluorescence. When we talk about the early hypofluorescence, the choroiditis is much more as compared to scleritis. And once this hypo goes into an hypofluorescence, it's always intralesional as far as choroiditis is concerned, but it's pinpoint and diffuse leakage as far as scleritis is concerned. Upon the B scan, there is a subtenon fluid space at the local scleritis patch. It is never a T sign. Please don't confuse a T sign to a localized subtenon fluid. T sign is seen in diffuse posterior scleritis. What we are talking about is a nodular posterior scleritis, where is a small subtenon fluid. This is a typical case of choroiditis. You can see the same kind of a yellow nodular lesion, early hypofluorescence, and then goes into progressive intralesional leakage. There is a minimal subretinal fluid as far as the OCT is concerned. Nothing on the B scan. But as far as nodular scleritis will go, so there is a small subtenon fluid over here, and the FFA shows pinpointed leakage. I'll just skip this 3 because sir has already spoken about tuberculosis. So a patient who has localized anterior recurrent or recalcitrant infection of endophthalmitis, if it's resistant to conventional therapy, how do we go about treating these patients? Case 1 among this group is a delayed postoperative endophthalmitis, which has been proved to be dematiaceous fungi. And the second case, the infectious scleritis with endophthalmitis, it's culture proven atypical mycobacterium in a retroviral positive patient. So the conventional treatment goes for, as far as the first case is concerned, so an iridectomy was done and antifungal was given, but you can see again a recurrence. The second case, at presentation, a scleral cut down was done, and then with intravitreal antibiotics with oral, nothing happened. There was a perforation leading to extrusion of the uveal tissue. So in such condition, what is the best option is an adjunctive double freeze thaw cryotherapy would help us. So the same case, after the first recurrence, cryo completely healed up. The second case, scleral patch graft was done. Before the scleral patch graft, cryotherapy was done to the localized area. In this, healed up completely. Case 5 is 3 easy ways to differentiate between fundus albipunctatus from benign fleck retina. If you look at the fundus photo, both are very much similar. If you see the fundus albipunctatus, it's the same kind of a lesion, millet size at the posterior pole and gradually increases into the periphery. I'll just skip to another one. That's the benign fleck retina, almost the same features. But the only difference is, as far as symptoms is concerned, patient has a stationary night blindness in albipunctatus, but fleck retina, it doesn't have any such symptoms. In ERG, there is absence of rod response as far as fundus albipunctus is concerned, but benign fleck retina doesn't have any electrophysiological changes. Case 6, can an asymptomatic nasal carrier of microorganism can be a source of acute postoperative endophthalmitis? Definitely, and yes. So this is one of the acute post-operative patients which presented with hypopion and endophthalmitis with a vision of hand movements. Vitreous biopsy showed vancomycin-resistant Staphylococcus aureus as an organism. The nasal swab of the first assistant was taken, and it showed the same organism of vancomycin-resistant. So both of the organism being the same, we cannot just set it alone. Asymptomatic nasal carriers of VRSA should be treated with mupirocin ointment twice a day for 10 days. So this is the patient at presentation, and after successful treatment has regained 20/40 vision. This would be the last case. A 64-year-old man with multiple venous occlusion associated risk factors like systemic hypertension, diabetes, and coronary heart disease, all features for him to present with a RVO. So this is a small superior temporal BRVO with a vision of 20/30. He has started to have some amount of macular edema over there. 10 months later, he presented with a increased occlusion, which a much larger cystoid macular edema and neurosensory detachment this time. So he was all this time maintained, the systemic status was maintained, that is his BP, hypertension, everything, and diabetes was controlled, and the CME was taken care with anti-VEGF agents. But coincidentally, in January 2007, he started developing hemorrhages that is related to the hemiretinal vein occlusion in the fellow eye. So despite his systemic conditions being normal, despite being taken care of the other conditions, why is he continuously on a downward slow progress? So the problem was, we did advice for a sleep study, and the features is patient had 73 episodes of apnea, 69 were obstructive, oxygen desaturation index was 44, and hypopnea index was 42. So the patient had a sleep dyspneic syndrome, and he was advised for CPAP for 6 hours during the sleep. So the catching the culprit, sleep apnea syndrome might sometimes influence the outcome of a RVO patient, not only RVO, even in diabetic macular edema patients who doesn't respond to conventional therapy. Okay, I'll stop with this.
Are there any comments or questions?
Any comments or questions as far as these cases are concerned? I am not help you completely because these were given by sir, and I could grasp only whatever knowledge that he could have imparted. If there is any doubts or anything that needs clarification.
In the last case, Mahesh, what do you think? Sleep apnea could have been contributory and not really causative of the whole picture.
Agreed. Like it's usually not causative; it's a contributory to whatever other systemic disease is there. But even now we wouldn't know whether it can be linked, because like anything else could not be linked to it. Like we are looking for hunting around the bush to see if there is anything else additional factor we are able to find, and sleep apnea probably has been found.
We have a paper, recent Dreams one. Raju's paper is the association of sleep apnea with this.
With the diabetic macular edema, Raju Raman was doing a study.
Yeah, he's doing.
Yeah, so that's
little
also
bit worsening is shown actually also.
Yes.
I mean, they are not responding just to.
Small study on sleep apnea syndrome. About 30 patients who had grade 2 or grade 3 sleep apnea were evaluated, and they were found to have reduced ocular perfusion, significantly reduced ocular perfusion, and their RNFLs were significantly different.
Yeah, the key is like do this if in case we are not able to find anything else. Sorry about this. None of the Macs are working. Apple computers are working with the projection system. Not only mine. That's why there are a lot of activity on the stage. Dr. Nitin will present this next. Yeah. Please go ahead.
We're presenting something like similar to last what Dr. Rajesh presented, but a little different. We have 4 cases, set of 2 cases, two cases here, 2 cases here, interlinked in some way. The first 2 cases are something which we see day in and day out, vein occlusions. Moral of the story of this is don't take these cases lightly. Do give a lot of consideration to these cases. This is a 59-year-old female patient, borderline diabetic at the time of presentation. This was in 2013. She was not on any treatment at that time. Presented with a recent onset decreased vision, typical branch retinal vein occlusion, 612 vision, systemically raised homocysteine, which was treated. Lipid profiles were normal. Now, this was treated as routine with anti-VEGF. We gave 1, 2, 3, 4 anti-VEGFs, did very well. Vision improved to 6/9. April, last anti-VEGF before this, before her presentation in April was in February, which we are given an anti-VEGF. In April, she came with a reduced vision again. This OCT showed retinal thickening in that eye, and then we gave an anti-VEGF, and we could actually, I'm sorry, the pictures may not be, we could actually see a lot of vascular abnormalities here in the temporal to the macula, where the perfused and non-perfused area, where typically you get the collaterals and vascular abnormalities. We decided to do laser to that also, but the problem was we gave the anti-VEGF, we had scheduled the laser a week later. For some reason it got delayed. Laser was done almost 6 to 8 weeks after the anti-VEGF. And about a month after doing that laser, patient presented with, within 3 weeks, she presented with sudden decreased vision in that eye and presented with quite significant exudation at the fovea in this eye. The macular edema had reduced, but there was still persistent edema at that stage. And after that, there was no way we could recover the vision. The vision kept going down. Ultimately, her vision was around 636, OCT showing some hyperreflective area at the fovea in that eye. Similar case, but slightly different in terms of this also presented with a superotemporal branch vein occlusion. You can see the AV crossing where the occlusion is occurring. This was sparing the fovea. This is something which we take lightly. It spared the fovea. You feel it's doing well. So we observed this patient. There was not much thickening at the macula. We didn't do anything for this patient. Was a hypertensive, well controlled. All the other labs were good. Patient over time started developing these vascular abnormalities in the temporal to the macula, and started developing some exudation. OCT, he started developing some thickness towards the fovea, and at which time we did the laser. Following laser, even this patient has increased exudation. Now, increased exudation is known to happen after when we do laser, but in this case, it was associated with increased thickness also. Luckily for him, the fovea was still not involved, so we gave an anti-VEGF with this, and patient did well subsequently. The fluid did come down, but subsequently we again saw the thickening again increasing. This is over a period of almost 4 years. This is not something which you're seeing month. This history also started in 2013. This last picture, what we are seeing below, is something which we have seen just 2 weeks back. So we are still struggling with this patient. So moral of the story is BRVO patients are not something to be taken lightly. These are long-term issues. Superotemporal BRVOs, where you see those temporal vascular abnormalities, be careful with these lesions. You can still have vision loss in patients who have fovea-sparing BRVOs. Increased lipid exudation can occur in these patients, especially in patients who have foveal thickening on OCT. In those cases, there is a possibility of exudates going under the fovea there. Take help of anti-VEGF, probably follow your laser just after the anti-VEGF, 1 or 2 weeks, and not allow the edema to come back. The second 2 set of cases are a little unusual presentations. This patient came with actually a decreased vision in the right eye. Left eye, he has had problems for quite a number of years, more than 10, 15 years. He's been to a number of centers, has had laser treatment done for that multiple times. The vision was less in the left eye. He was quite okay with it. The reason for presentation was the right eye vision came down, and he had a typical CSR in the right eye. He was on some homeopathic medication last 3 months. OCT, FFA, OCT, everything was typical of CSR in the right eye. So the right eye is not the question here. Left eye had features suggestive of a variant of Coats disease. He had those typical vascular abnormalities. Even though the changes were central, he had some peripheral laser marks also. What was peculiar in this patient was the OCT finding. Now, if you see the OCT here, you have a huge dome-shaped elevation. Then what is important to note is that small ridge of retina at the edge of the elevation. Now, this is typically described in Terson syndrome, where you have ILM separation. You have sudden separation of the ILM, and that ILM comes out and it pulls out the retina as a ridge or around that. And this patient actually had when we saw him, there was some bleed in front of the retina. And you can see in this next 2 pictures, this was over a follow-up of about 2 months. You can't see the retinal details in this picture. You can see the retinal details. So there was some clearing of the subretinal blood, sub-ILM blood in that eye. And when we did the serial OCT over a period of time, the sub-ILM fluid went on reducing. It's not yet reattached. This picture was just about recent, so I'll probably be following next year. If Mahesh has an X-Files, we may present something with the reattached ILM. I'm not too sure. I would expect it to reattach once the fluid goes off. So this is something which we don't very commonly see as an OCT presentation. Second patient is a totally different etiology, but a little mimicking findings. Is a typical CREO patient who presented, had all multiple systemic risk factors for a CRVO, had cardiovascular issues, presented typical CRVO. And if you look at his OCT again, there is sort of a dome-shaped elevation layer in the central part over the macula. And if you look at the fundus picture, actually, before the fundus picture, in the CREO, you could see some sort of a granular deposit over the retina. This is something which we don't commonly see in CREO patients. This was on the retinal surface that you were seeing. And the OCT tells us why that is there. Probably what we can hypothesize from this is the sudden axoplasmic stasis that occurs because of the CREO builds up the internal pressure, and the fovea being the most weakest area, that sort of ruptures out, and what you're seeing in the sub-ILM space are all the debris, the retinal debris, necrotic debris that you're seeing. Now, this also had actually a small ridge at the edge there. So this again is an ILM separation, what you're seeing in this eye. Now, these are little uncommon findings, but something we may be seeing and may be missing if you're not aware of this. So just to highlight is that ILM separations can happen in cases other than Terson syndrome. Thank you.
Are there any comments or questions on the cases?
Sorry, I joined late in the talk. In the last case you showed, was there any uveitis in that patient?
No uveitis.
This is a picture which is shown in the SSPE lesion.
Pardon?
SSPE.
No. This was a very typical central retinal artery occlusion.
I know, but
if
there
I'm
are
not
pictures
mistaken.
which are published there.
Pardon?
Pictures published, the similar pictures are there, seen in the SSP.
No.
This is how the retina behaves.
No. This is a
After
very
that
typical. I don't have the angiograms here, but it's a very typical.
So this is how SSP also behaves. You have this
Not
vasculitic occlusion.
No, not too
Extremely
sure.
vascular
I'm not too
occlusion.
sure. I'm not too sure. No.
There, it may also published from our.
No neurological symptoms in this patient. Usually it follows the neurological SSP. Usually neurological. There's nothing in this patient. If I'm not mistaken, there was a case which was discussed in over retinitis. It's very similar. So I don't know who had presented. At the same time, I had also seen something similar, so I had given a thought to that. But there was a similar case presented on retinitis also.
Yeah, I agree. But I agree, like SSP can also present like this, but then, like, of course, usually by the time the eye signs are, the patient does have some neurological signs. So that's usually what happens. And this patient must be on a follow-up.
No, he was lost.
He was
I
lost
couldn't
to
see him
follow.
after that.
Okay.
I couldn't see him.
So in the vein occlusions, like you showed the vascular occlusions in one of the cases, and then the temporal part.
Yes.
So what do you attribute those to?
Vascular occlusion.
You showed those deposits within the.
Where we treated.
Yes.
See, these are basically at the junction of the perfuse, non-perfuse. So would expect that to be some kind of a reproliferation happening there. Collaterals we say don't leak, but these were exuding quite a bit actually in that area. Technically put it as collateral or vascular remodeling in that particular area, but they're typically at the junction of the BRVO and the normal retina. That's where both the cases had those vascular abnormalities that we got.
Okay. Yeah, that. Yeah. Correct. The Coates disease, like sometimes it responds better to steroids along with this.
He was not keen on the electric treatment at all. He was happy with his experience.
Yeah, but of course, like if you give steroid, this eye CSR may get worse.
Yeah.
The other eye CSR may get worse. Yes, that's also true. Intravitreal steroid. Like at least in children, I use intravitreal steroid that works much better than anti-VEGF agents actually.
Intravit should be okay. CSR has never been reported.
Sure. I'll request Dr. Saravanan to present his series of cases.
Thank you, sir. Just go fast. And this is like an old 14-year-old boy with a giant retinal tear. During fluid air exchange during vitrectomy. So what we usually do is start injecting through the infusion cannula in 20 gauge surgery. But in MIVS, a small tip what we can do is, like you can see here, the lot of folds on the central macula. You can see this is following the fluid air exchange. So what we do is just reconvert it to fluid and then inject PFCL again, reflatten the retina. So that is done. And now instead of injecting through the infusion, which is not possible in MIBS because with the high pressure needed, the plastic tube just comes off. So instead of that, we are just inserting a 25 gauge torpedo light, and superior two ports will be used for the direct silicon oil PFCL exchange. So the non-dominant hand use the oil injector, and the dominant hand use a passive suction. So as the oil goes inside, the pressure builds in, and the fluid will come out through the passive suction. So initially you keep the tip just above the level of the PFCL. Once you are sure that most of the DSS come out, then you can shift to the optic nerve and remove the rest of the PFCL from the posterior pole. The last bit you have to be a little bit careful because there's a chance of tugging the macula and creating iatrogenic holes near the macula, either in the macula or just in and around the macula. So do that part only along with active suction. So right now we are doing only passive suction as oil is going inside. Now initially the BSS is coming off. Once you are sure most of the BSS is come off, then you can directly shift the tip of the suction cannula to the optic nerve and remove the rest of the PFCL. So using a torpedo light, we can obviate the need for injecting through the infusion cannula, where it will take a long time because you have to use very low pressures. You can see the PFCL is coming out now. Only the last bit where the small bubble is lying right over the posterior pole. It's a little bit risky to remove with passive suction, so there we go for active suction to remove this bit. This is one thing that I use for. So this is one more history. Is a one-eyed male with a proliferative diabetic over the vitreous hemorrhage. Left eye is high myopic with no vision, reprovision 263 vision. So first we did vitrectomy. He had a recurrent vitreous hemorrhage. Then we injected silicone oil. After close to a year, we removed the oil. Again had a recurrent bout of vitreous hemorrhage. We did the antiretinal cryoablation along with cryo to the ports twice. Again recurrence. So we re-injected oil. After 1.5 years, we removed the oil. Again he had a recurrence. So after SOR, after IOL exchange, cataract removal and SOR. So now what do? We have injected oil twice and removed twice. Still is having recurrent this thing. So what we tried here was the first case which we did. We did a laser to communicate the anterior chamber and the vitreous cavity. So whenever he has a bout of hemorrhage, he says that it clears within 2 to 3 hours. He just goes and sits in a corner, and the blood clears very fast through the anterior chamber angle, and it may cause a slight spike depending upon the amount of blood, but it immediately clears. Nowadays, he says every once in 2 months or 3 months, I get a small boat, I go and sit in the corner. After 2 or 3 hours, it becomes clear and starts blooming out. So after this became successful, we have been doing this as a surgical option also. So in malignant glaucoma, what we do is we try to rupture the anterior hyaloid base and the posterior capsule, and try to communicate the posterior anterior vitreous to the anterior chamber, creating a peripheral diaphragm, capsulectomy, and orogenic. So that way we make this communicate. Similarly, just what we do for malignant glaucoma, xenophakic malignant glaucoma, which is two-port vitrectomy is done. Of the anterior chamber. This is what we do for malignant glaucoma. So we started doing this for patients with recurrent vitreous hemorrhage also. This is one patient with recurrent vitreous hemorrhage. Instead of doing oil fill, just doing a peripheral iridectomy and capsulectomy. So whatever blood comes in, it will drain through the anterior chamber. Only caveat is that you have to ensure that proper laser is done. Otherwise, you can go for a neovascular glaucoma. So posterior pole should be properly lasered. This one patient, again one-eyed patient, other eye had a failed RB surgery, PDR, recurrent vitreous hemorrhage. She came with a bout of vitreous hemorrhage after 1.5 months after plain vitrectomy with no oil fill. So this is a fake clear lens. He's around 36-year-old male. He's got a clear lens. So again, similar to what we can see the blood coming out, just doing a vitreous lavage to clear off the blood. And so once that is done, you put a AC maintainer and through the anterior chamber do a peripheral iridectomy and zonulectomy, avoiding damage to the lens. So now again we are doing the same thing. We are communicating the anterior chamber to the to the vitreous cavity. So now we have to check whether this thing is working. So you just see that the same thing. Just use a cyclovas spatula and see whether the flow is communicating either from the anterior chamber maintainer should come to the vitreous cavity, from the vitreous infusion it should come to the anterior chamber. This is after 1 week, you can see the pattern without no changes in the lens. You can see the pattern PI, and we had recovered 6/9 vision immediately after 1 week after the surgery. So one more thing which you notice during injection of any dye or any PFCL into the vitreous cavity is injury to the posterior pole because of the jet stream. Because you're using a rubber cork. You can see it goes as a small stream, and sometimes what can happen is it can hit the macula and balloon up or make the macula hole bigger, and the edges can tear off, causing a flower petal pattern. So it may increase the damage to the fovea when injecting directly on the fovea. Or like, and a lot of the reports are already there where the dye has migrated into the subretinal space, causing degenerative changes. So this is one more case where one of my junior colleagues, when he injected PFCL, you can see the PFCL has created a macula hole directly and gone under the macula. He didn't realize it. Now the posterior pole RD after injected PFCL. This is a small injury because of the initial ILM peel which was trying to do because of the presence of posterior PVR. So we are trying to remove the PFCL from the subretinal space through the macular hole itself and then trying to get access to the retina. So how to avoid this injury? So the thing is, you have to use syringes. I'm sorry, the second part of the image is not coming. You can see that here, there is a rubber cork, and the second syringe, in the bottom syringe, there's no rubber cork. Use a syringe which has got no rubber cork there so that it goes in smoothly, or you can also use a glass syringe to obviate this. So this is one case where you have a epiretinal membrane with a foveal schisis and foveal cyst. How to peel without creating a iatrogenic macular hole. So what happens is when you're trying to peel across, like you peel the ILM in a macular hole surgery, what happens is because of the traction on the fovea, the thin fovea can just rip off, creating a iatrogenic macular hole. So at this point, you can see that the fovea is getting tagged there. So if you try to pull it right across, you may create a iatrogenic macular hole. So best is to peel. You can see there the small tag is fovea is getting lifted up, which can rip off. So what you do is you try to peel all around and see that the last point of the membrane coming out should be from the fovea. The last point of release should be from the fovea rather than right across. So peel all around, and thereby you can peel it more safely, avoiding the iatrogenic macular hole. So there's a small animation showing how we do it. So if you try to peel it across in routine ERMs, it's okay, but if the already fovea is thin, it can rip, creating a iatrogenic macular hole. Instead of that, you just try to peel all around, and the last point of release should be from the foveal center. So one more thing is, don't try to hold your breath. So sometimes you see juniors when they are operating, their hands are very shaking. The thing they are trying to do is they're trying to hold the breath so that they are more concentrated, or either intentionally or non-intentionally. So never, when you're doing a very fine surgery, don't try to hold your breath. Try to consciously breathe slow, so that way you can be a little bit more easy and more safe when you're trying to address these very critical areas where even a small shake of the hand can create injuries. There's a small clip from the Kung Fu Panda movie where you're saying that I'm trying to breathe in and out so that I can get you can even handle the dew falling without breaking the dew bubble. So make sure that you consciously breathe in and out slowly when you're doing ILM peeling or IRM peeling. There's two small tips: how to identify oil in the AC. This is, you can see the small shiny surface of the iris. Sometimes junior people have, when there's a full fill, it is difficult to identify the presence of oil in the antechamber, especially if the ciliary body is not functioning properly and the IOP is high. So what you can do is you can do a UBM. In a UBM, normally the iris is, how it looks like this. The lens, the iris configuration looks like this. But in an oil eye, this will be more like a funnel. You can see this shape will be more like a funnel. If you're not sure whether oil is filling the AC completely, you're not able to identify with slit lamp, you can do a UBM. And sometimes stand off using ultrasound also. This is the cornea and this is the iris. This is the normal configuration in a normal patient where the oil is not there in the antechamber. And when it is in the anterior chamber, you can see that it's more like a funnel shape. The cornea is flat because of the hypotony, because of the pressure of the probe. But you can see that the iris is more bowed posteriorly because of the conical shape. This will just skip. And And this is for, like last time we were discussing about the how to differentiate between FEVR and vasculitis. So if you see this nicking here, this is a point to differentiate between vasculitis and FEVR. This nicking which you see is typical of vasculitis or a PDR, any obstructive retinal disease. This is how you see in a FEVR. There's no nicking, there's usually AV communication. And usually you may be able to pick up the small apex arrowhead-like configuration pointing towards the fovea. And during vitrectomy, it is impossible to peel the vitreous from these surfaces. So you'll have to do with shaving rather than. Thank you. I'll stop here.
Thank you, Dr. Saronan, for that series of cases. I had a question about the vitreous hemorrhage. So, how many cases do you have where the
Lasers we done close to around 25 cases. Surgery we have done around 10 cases. Phakic eye only 1 eye.
So, is there any particular corner they have to go and sit?
What is that?
Is there any particular corner the patient has to go and sit? No, but they continue to develop recurrent vitreous hemorrhage, right? So, but like it clears faster.
Very fast.
Very fastest?
Like if it's a small board within hours. Like
Okay.
the first patient I told you, every time he has 2-3 hours only. But some people, depending upon the intensity of the bleed or the volume of the bleed, it may take even 6 hours.
But any of them have developed increased intraocular pressure?
It may be transient, sir. During depending on the amount of blood. NVG is a concern if you're not laser the posterior fold properly.
But then wouldn't you go back and see for the cause for the recurrent vitreous hemorrhage?
That we do, sir. When you're doing this cutting, we usually do vitreous lavage and search for any recurrent membranes or any new presence of leftover new vessels. But a lot of times, it's mostly because the anterior highlight after which is very difficult to identify.
You do UVM also for these eyes. UVM to just identify.
We don't have the UVM. Recently only got
Because
UVM.
so many times if you do UVM, then you'll pick up these things, and even sometimes we do laser or anterior right up to the aura, and sometimes even little bit go on a pass plan, and generally after that there's no problem.
Eyes we do laser through the aura after the recurrence has happened, but still they continue to bleed.
Yeah, I in addition put a belt buckle also.
Yeah, if you have still you can't relieve that one. Sometimes I can identify proliferation. I will go trim that whole thing right flush to the and then cauterize this point. Usually you find those fleshy thing at a sclerotomy site. You can give intravitreal like anti-VEGF, but it works for a while. Again, it just comes back. So what I prefer is around series of 37 cases I have to write now. So the stream that UVM shows typical picture. Of course, phakic eye sometimes when you see you may have to sacrifice lens to reach those areas, and just stream flush, cauterize those areas and go anteriorly doing laser. Most of these eyes they do well, and suppose during the flushing, suppose you're damaged, you created iatrogenic break or something, you are worried about doubtful breaks, then adding encirclage plus silicone oil and then SOR later on, most of the time into. So.
Thank you, Dr.
Thank you.
Dr. Rajesh will be presenting a large series of cases.
Thank you, sir. So, extrapolation of masquerades, the surface features precluding the underlying diagnosis. That is, obviously, we look at the surface features and don't look at what is really happening at the depth. Leads on to wrong diagnosis, inappropriate therapy, and delay in the appropriate treatment for the particular condition. So, let us go through a series of patients who had idiopathic thrombocytic purpura and then see how it manifests in the eye. So, clinical syndrome, it is basically a thrombocytopenia, that's it, which has bleeding tendencies, easy bruisability, and petechial hemorrhages as far as the skin is concerned. It can also present with features suggestive of other disease etiology in the eye. Let us go to the first case scenario. A 63-year-old gentleman, known patient of diabetic retinopathy. He has been treated for having cystoid macular edema with neurosensory detachment with multiple anti-VEGF injections and laser. He has a fairly good moderate systemic control. HbA1c is about 7.5. So if we look at the fundus, this is how the presentation is. The thing which really catchy is the large hemorrhages which are intraretinal. It's not a typical feature of a patient presenting with diabetic retinopathy. As far as OCT is concerned, he has CSME with CME in both the eyes. So, I mean, thinking of an alternative diagnosis, getting an entire workup done, hemogram was one of the top of my list. So, patient was diagnosed with thrombocytopenia, sent him for a physician. So, he diagnosed as ITP and started him on low dose steroids because he was moderately controlled diabetes patient. So, as far as the eye is concerned, we didn't do anything. You could see that at 5 months of conservative management, the hemorrhages are much better, the RDX rates are resolving by itself, the edema is also coming up. The 7 months follow-up, again further betterment of the fundus status is concerned. At 16 months of follow-up, without any activity at all, the one deteriorating factor was the left eye had a vitreous hemorrhage. So did we miss out on anything where the patient was progressing from an NPDR to a PDR? We did an FFA to see there was nothing much to suggest of any neovascularization. So continuing the same kind of a masterly inactivity or a conservative management, at the end of 3 years you can see how wonderfully the retinal hemorrhages, edema, art exudates have completely cleared off. So suggesting that it was the ITP which was in play rather than the diabetic retinopathy per se. So as far as the learning points is concerned, we have to look for blotchy hemorrhages, which is not typical of diabetic retinopathy. Systemic investigations, we all, brush it aside, saying that as far as various protocols that we have, if a patient present to us with a diabetic macular edema, so-called diabetic macular edema, we start treating them, neglecting all the systemic parameters as such. And even if we do a systemic parameter, we just limit it to the HbA1c, that's it, say that, okay, it's controlled fine. So enlarging the list of investigation, just adding upon another 200 to 300 rupees to his investigation bill doesn't cost much, but it leads on to various, identification of such, masquerades. Even in some patients we have found out where the patient was a leukemic and lymphoma, and the patient had presenting features which was very much similar to the diabetic retinopathy and CSME, but it was not related to that. So another clue is the patient had received multiple anti-VEGF, the response was not great. It's not that he was responding and then it was coming back, the response was very, very less. So we have to ponder upon whether there is any alternative diagnosis to the cause of macular edema which is not responsive to the anti-VEGF, which is a conventional therapy. Let us go to the second scenario. A 29 years old gentleman presented with right eye black spot, sudden onset 3 days back, and he was suspected as PCV elsewhere and services. Though the age doesn't really correlate, we have been having reports saying that younger age Asian patients can present with PCV. So this is how the fundus which are presented with. You can see there is a blotch of hemorrhages at the supranasal quadrant of the optic disc, and there is some component of the subretinal hemorrhages. We told him we'll just wait because nothing was fitting in much, and 4 days later he came back saying that the spot had enlarged and the subretinal hemorrhage also had increased. At this point of time we hadn't got any investigation done. So fearing that it might enlarge or some other underlying sinister pathology might be there, we went in and did an ICG. And obviously we didn't get anything at all. The choroidal vessels were absolutely fine, the retinal vessels were absolutely fine. At this point of time, looking at the back case scenario, so we went ahead and did an hemogram once again and found that he had a thrombocytopenia. There are other earlier case reports which suggest that spontaneous bilateral peripapillary, suboiloid and vitreous at multiple levels with severe anemia can be secondary to idiopathic thrombocytopenia purpura. So we contributed the manifesting features to the same thing and waited, and 3 months later he had a complete clearance of the underlying problem, obviously along with the treatment for the ITP person. So learning point from this case is it can present with a large hemorrhage. We have to always look for an underlying vascular anomaly. If not proven, then we have to consider ITP as one of the features. Ophthalmic investigation which aids us is definitely an FFA and ICG and OCT sometimes. No need to treat obviously because the specific problem is not in the eye, it's in the systemic manifestation. So coming to a third one of our curious cases, a 32-year-old lady complained to us with a sudden onset of blurred vision in her right eye since 2 to 3 hours. She is a known patient of ITP. The platelet count at that point of time was about 40,000. She was already on steroids. There was no systemic problems as such. There was nothing as petechial hemorrhages or any manifestation of thrombocytopenia. So this was the manifestation. Left eye was absolutely fine. The right eye has a dense hemorrhage which is at the retinal level and subretinal component also. So we said we'll just wait for some time because ITP, the second case, now based on that, we said that okay, there might be just an hemorrhage spontaneous, it will regress. So just wait for some time and come back because we couldn't identify anything else. So an FFA was done because the patient was persistently asking for a investigation. Nothing much that could be identified at this point of time. If you look into the other one, a peripapillary CNVM or a PCV can present with a polyps or a lacy leakage, which was not there in our case. 4 days later, she came back with a further drop in vision. At this point of time, the platelet had dropped by another 8,000, and she was cursing us because the hemorrhage you can see was right damn bang onto the fovea. It's a subfoveal hemorrhage, and it was increasing, and there was a breakthrough vitreous hemorrhage also. So at this point of time, we had to give us something to manage it. So what we best thought was to clear the hemorrhage over there from the fovea. We gave an anti-VEGF with C3F8 with a prone position to make sure that the blood clears from the foveal end. This was a pre-injection status, and this was a post-injection 3 days. The other features which was very much not into this part is the hard exudates which was arising all around the fovea. 1 week later, we just waited, we didn't do anything much. We could see something like a blood vessels, abnormal blood vessels at the disc, which was very suspicious. So we went and did the ICG. ICG showed those abnormal blood vessels and something like a capping over here. You could appreciate. So an FFA, that showed a fluorescein, classic fluorescein capping over here. So basically this patient had a cavernous hemangioma of the disc. It's a quite rare hematoma. It's unilateral and primarily in females. Clusters of sacral aneurysm filled with dark venous blood is a characteristic feature of this. Very much whichever was there. The fluorescein caps are sacral dilatation because the clotted blood sediments down and the circulation is what we can see as a cap over there. So there's no prescribed treatment as far as cavernous hemangioma is concerned. Focal laser therapy has been advocated in a few conditions, but it causes visual damage as well as field loss. So what I thought was like, let us go ahead with a PDT per se and see what happens to this. So I did a R-fluence very close to the disc and a full fluence just away from the disc about 3.2 mm. And to my surprise, at 2 weeks post PDT, the abnormal vasculature was completely gone. 6 months later, the vision was 20/20. There was nothing underlying. The blood vessels hadn't recurred. I don't know why. There was no field loss also. So learning point from this is ITP may not only present in isolation, might aggravate the underlying unrelated pathology. In our condition, the cavernous hemangioma. The systemic investigation, along with that imaging modality, plays an important role to establish the proper diagnosis. PDT was an effective treatment as far as cavernous hemangioma. First time in literature we are trying to publish this. So as far as ITP is concerned, these are the three case scenarios which I wanted to present. I'll just go to one more case. This patient presented with a Kushner's kind of a retinopathy kind of a picture over there. There was no trauma, no recent hospitalization at all. The characteristic feature which was over here is there was a large cotton wool spot kind of a retinal whitening, but the retinal whitening didn't have a para-arterial clearing, which is usually a characteristic feature of Kushner's retinopathy. The underlying problem was we took a blood sample and sent it for investigation because multiple myeloma patients might present like this, and to our, whatever suspect, it turned out to be a plasmacytoid cells, and it was a patient of multiple myeloma. So learning points as far as this case is concerned, hyperviscosity syndrome such as multiple myeloma can present with Kushner's kind of retinopathy. Why no para-arterial clearing exactly is not well known, but the only issue is when such patients develop such lesions in the retina, the 5-year prognosis rate has been shown to be very less. Thank you.
Thanks, Dr.
Manifest by itself spontaneously, and you do an investigation like FFA and ICG and nothing comes out. So hemogram, just an hemogram will definitely, not in terms of ITP, other features also, so better to get it done. On the other hand, like diabetic retinopathy patient who doesn't really respond to the conventional treatment, I generally in my workup of patients do an hemogram, peripheral smear as such, in additional with renal function test, lipid profile and glycosylated hemoglobin.
Are there any comments or questions? Dr. Khema? Yeah, silicona the intracranial. Intracranial, what has been reported is an elevation of intraocular pressure. So a single attack of intraocular pressure can push the oil into the chiasm. It's been reported in a few patients into the optic nerve and into the chiasm. It's not been reported, but it's associated with one attack of elevated intraocular pressure. Not a sustained attack of intraocular pressure is not required. So this patient had a history of intraocular pressure going up to around 35 once, and it was immediately controlled. but that has pushed the oil into the chiasm. So that is the risk factor. Whether associated anomalies in the optic nerve are like related or not, it's not, the literature doesn't support that. Literature doesn't show that. If there's an optic disc pit, patient with optic disc pit or patient with coloboma choroid, whether they have an increased risk, that's again not related. And as far as the vitreous hemorrhage, recurrent vitreous hemorrhage is concerned, there are 2 or 3 reasons. If it occurs in the immediate post-op period within about a week's time, it's usually the opening up of the blood vessels. I wouldn't be much concerned. If it happens about 2 weeks later, that's usually an anterior proliferation. Then I would usually have an UBM done to see if there's an anterior proliferation, or the peripheral vitreous which is attached to the retina and not peeled off or could not be peeled off during the surgery, attached to the neovascular proliferation. When it detaches subsequently, that is the one which gives rise to recurrent bleeding. So that's why I usually go the whole hog by putting an encircling band, peripheral cryo or laser up to the ora and an anti-VEGF agent. And in the recent patient whom we had operated about 2-3 weeks back, I found the neovascular proliferation, just a single twig. It could not be picked up on UBM, but just a single twig growing from the pars plana into the eye. So when extreme depression of the pars plana, I could identify it and cauterize it and remove it. Yeah, doctor.
There's just one comment. The large blotchy hemorrhages that Dr. Rajesh showed, so it's a very common presentation of ocular ischemic syndrome. So I think that should be one of the part of the investigation. Do a carotid Doppler, and many times then not, if there are large blot hemorrhages, you'll find carotid occlusive disease.
So can be definitely, but in this patient there was no other features. Yeah, totally agree.
I think if there are no further questions, I thank my co-instructors, Dr. Pramod, Dr. Nitin, Dr. Saravanan, Dr. Avinash and Dr. Rajesh, and thank you all. I hope you had a good time. Thank you very much.